Hi, everyone, and welcome to today's session, How to Successfully Achieve DSMES Services Certification from ADA and ADCES. My name is Ryan Kuriakos, Senior Marketing Manager here at Gluco, and I'm excited to have all you guys join us today for the fourth and final webinar in our four-part Diabetes Connected Care series. Marianne Hodorowicz is a registered dietitian, nutritionist, and a certified diabetes educator. Marianne is also a certified endocrinology coder and earned her MBA with a concentration in marketing. She's nationally recognized in many areas of diabetes care, especially in Medicare, managed care, and commercial payer reimbursement. In this capacity, she has worked with hundreds of healthcare professionals and entities, professional membership associations, and government agencies across the country. We're thrilled to have Marianne join us again today for this fourth webinar so she can share her wealth of knowledge on DSMES certification. Now, without further ado, I'll pass it to Marianne.
Hello, everyone. I am so thrilled to be with you today. This is Marianne speaking. And Ryan, can you hear my voice okay?
Loud and clear. Thank you.
Oh, perfect. Okay. So, ladies and gentlemen, if my voice starts to trail off on your end, please indicate that in the chat box, the Q&A chat box. And please, throughout the whole webinar, enter any questions you have whatsoever. There's no question too small or too irrelevant to drop in that chat box. You're also welcome to drop in how you're liking it, how you don't like the webinar, any suggestions, any experiences you have with anything I'm talking about today. We would just love anything you want to drop in there. That would be great. I'm in my dining room right now. I'm in Palos Heights, Illinois. I was just telling Ryan and Erica at Gluco that we have severe storms threatening our area right about this time. So let's keep our fingers crossed that that doesn't happen and we don't lose this connection. So we have a lot of content to cover. I'm going to talk not really rapidly, but what I'm going to do is not really read word for word from every slide. I do this with all my webinars and even my live presentations as I verbalize what I call the key core messages on each slide, which may be only 10 words or less, and there could be 100 words on the slide. But I always format the decks with all the details that you need because I want the deck to be your resource library, your Wikipedia on the subject. So you have it to take back to your work setting or your home where you can read in detail all the details that you need to be successful on the subject matter. So to save time, I'm not going to go through the learning objectives. And let's get through these introductory slides. But again, just to reiterate what Ryan announced is that in the middle of this deck, we are going to take a Q&A for 2 or 3 minutes, and Ryan will read me the questions or your comments or your concerns. And then we'll do it again before the top of that hour, probably about 5 till the end of the program. And then we're going to do an extra 15 minutes for those of you who can stay. Key terms and abbreviations, diabetes self-management training, T, training, that's the term that Medicare uses for this benefit. The rest of the world calls it diabetes self-management education and support. For the sake of this webinar, it's a mouthful, right? I'm just going to say diabetes ed or diabetes education. What's going to be significant in today's webinar are the national standards of diabetes ed, diabetes self-management education and support, the 2017 edition, which is the current standards right now. There's 10 of them. They're written and revised every 5 or 6 years by an independent joint task force. And Medicare does have to approve them because Medicare does pay for this benefit, and adherence to the national standards by the organization who wants certification is absolutely critical. So there's many definitions of DSMES throughout the years. I've just written some of these for you here, and again, this is to support you if you want to promote the adoption of this service in your organization. This is to help you holistically moving forward with this benefit if you're not doing it quite yet. The AADE is now called ADCES. the Association of Diabetes Care and Education Specialists. But their old name, AADE, is still being used for the self-care behaviors that have been branded and initiated by the organization several years ago. So this is what we still focus on to teach our patients. And I'm sure many of you on this webinar have seen these over and over again. So the AADE name is still being used. And this is really the 7 core educational topics that we are to focus on in the curriculum. So why is DSMES needed? Because, well, patients with diabetes need the education, pretty simple. And just so you know, if you need to promote this program, ADCES has position papers on the value. They have a great position paper that just actually came out yesterday for 2020 on the value of DSMES for adults with type 2 diabetes. The ADA has position papers and resources that prove the value and why it's needed. So why should you seek ADCES accreditation or ADA recognition? 2 different terms. Because first of all, Medicare requires it to be reimbursed, and it is a mark of quality. And many other insurers do require this. Some Medicaid programs and some private payers also require this, but it is a gold standard of quality. And so how we get certified, and that's the term Medicare uses, certification. ADA calls it recognition, ADCES calls it accreditation. It's all the same thing. So how we get this, the certification, is what we're going to do now in this webinar. So again, when we get this gold standard of quality, accreditation, recognition, Medicare certification, that means we've proven that we're adhering to evidence-based standards, many rigorous regulatory requirements, and it all boils down to that will lead to improved patient outcomes, more revenue for the organization because this is required by many payers, and we're now furnishing a very underutilized service for Medicare beneficiaries, Medicaid subscribers, and many private insurance subscribers. It's very much underutilized, and that's really sad. Causes me great distress because it's been proven to be of high value to our patients with diabetes, and it does significantly improve outcomes. And so speaking of outcomes, actually there's a spectrum of outcomes that are important. And you're saying, Marianne, why are you going through this? Well, one of the requirements for getting, I'm just going to say certification, and that means ADCES accreditation or ADA recognition. I'm just going to say certification. One of the requirements from those 2 associations is we have to track outcomes in the program and report an aggregate summary of those outcomes to get the initial certification and for every 4-year cycle to get recertified. And there's a pecking order to outcomes. And we're going to start here on the top left and go down to the bottom right. And again, even if you don't track all of these, you don't have to track all of them for certification. The clinical or what are the critical ones for certification. But I'm highly recommending you track all of them in order to sustain your diabetes ed program. Sustainability, marketability, proving your value. Outcomes prove your value and the value of your program. So starting in the top left, we want to track knowledge outcomes of Martha, our patient. We're just going to say Martha to represent all of our patients with diabetes. A knowledge of the 7 AADE7 topics on a scale of 1 to 10. Knowledge, just really simple. And again, Gluco was kind enough to allow a lot of my outcome forms that you can use and a lot of chart forms that are going to be required for certification. I gave them to Gluco, and it's part of what you can upload now, or download, I should say, after this webinar. You have my outcome tracking forms, my education plan, the design of the program, all those things you need to make this easier for you, especially outcome tracking. So once Martha gets a knowledge outcome, hopefully that's going to lead to a behavior change outcome. This is a domino effect. One begets the next. Behavior change leads to a clinical outcome, improvement in A1C, fasting blood sugar. Clinical outcomes lead to quality of life. less urination, less blurry vision, better sleep quality, less tingling in the extremities, less anxiety, less extreme hunger, less weight loss. And that category of outcomes, just so you know, ladies and gentlemen, it is the most sought after outcomes from the patient perspective. Numerous studies have been done that shows that patients with diabetes, when they receive these kind of services, what they're seeking first and foremost is quality of life outcomes. What affects them today in the present tense? And all of those outcomes will lead to cost savings, less medications. That means less out-of-pocket payment, less trips to the ER. It's cost savings. And then at the bottom, all of those outcomes combined lead to satisfaction outcomes. And we can track all of these: patient satisfaction, provider satisfaction, and payer. And I have, again, a satisfaction survey form I can share with you, a provider satisfaction survey form I can share with you. You just have to ask. But again, Gluco has uploaded many of my forms that you can then download today after this webinar. So certification is the first step in getting reimbursed by Medicare. We need that for Medicare for sure, and many other payers. And we know that this is paid for by Part B, Diabetes Self-Management Training. There's your reimbursement rates and the procedure codes we have to use. But those rates listed on the right, they vary by geographic region. The rates listed are the national geographically unadjusted rates, and that's for a 30-minute unit of time. And you input the number of units of time furnished on the claim form, and then there's the multiplier effect. So the benefits of accreditation from ADCES or recognition from ADA, again, Medicare calls it certification, they spell vital. I'm not going to go through this because, again, remember that really, I would say 50% of the reason I give you this very comprehensive deck is so that you have all this detail so you can propose adopting this program to your administration to furnish the program. Or if your administration, you already have the program and they're thinking of disbanding it, you can use this information to fight the semi-decision to disband it. So again, this is really good background information that you'll be able to use moving forward. Again, just remember certification, accreditation, recognition, it means all the same thing. And Medicare has to approve the accreditation requirements coming out of ADCES, and they have to approve the ADA recognition requirements, and they're a little bit different. If you go with ADCES versus ADA, there's a little bit difference in the two, not much, but a little bit, and we will go through that today. So this is what the website looks like, and the website still calls it AADE. They're still using that term because that's still the term Medicare uses instead of ADCES. But AADE calls it Diabetes Education Accreditation Program, or DAP. That's what they call it. So you have a lot of resources here on their website that will help you tremendously. This is ADA's homepage for their recognition, and they call it ERP, E-R-P. You see at the top, little toward the left, Education Recognition Program. So DAP and ERP are the names that each of those associations call it. And again, there's requirements that are a little bit different within each, but the bulk of the requirements to get this certification are the same, but there are a little bit of differences. So one of the major things you have to do to get certification from either one of these associations is to show evidence in writing that you're going to adhere to the 2017 National Standards for DSMES. We have structure, process, and outcome standards. They're categorized in 3 buckets. So standard 1 through 4 is what they call the structure standards. We're going to go through each of these. So don't worry that I don't go through them right now. We are going to review them. And standards 5 through 8 are what we call the process standards. And then standards 9 and 10 are what's called the outcome standards. So structure, process, and outcome. Now that's not my terminology. That's the independent task force that writes these standards and revises them every 5 or 6 years. So now this next part is going to be what I created for you, what I consider the 16 steps to achieve the ADA recognition or ADCES accreditation. And some of you know I'm the queen of acronyms, the queen of mnemonics. I just love creating them. You know, I'm an empty nester, just my husband and I in the home. And when we're watching, you know, a movie for the 20th time in the evening, I get out my pad of paper and I start writing acronyms and mnemonics. I just love doing it. So let's go through what I consider the 16 essential steps. Now, as we go through here, the AR, if you see AR, that means it's an application requirement to get the initial certification by ADCES or ADA, an application requirement specifically by ADCES or ADA. So, and then SO is the sponsoring organization. That's the hospital, the clinic, the physician group, the RD private practice, the pharmacy, who gets the initial accreditation or recognition. So that's considered the sponsoring organization. So step one, we have to determine who wants the certification, who wants it, where the location of the diabetes ed program, what is going to be the primary location? Is it going to be the hospital, the same as the sponsoring org? We need to determine the quality coordinator, and that's what it's called, the head of the program. And then the certification organization, the CO. Are we going to choose ADCES or ADA? And it's the only two we have to choose from. It's the only two that Medicare has approved. Remember, Medicare grants this certification blessing to the organizations who want to deliver that certification. And so far, it's only these two. The second step is we have to ensure the full support of the program from the sponsoring organization's administration. And this is a requirement by ADCES or ADA. We have to have a letter of support. This is part of the initial application by either one of these associations. You have to have a letter of support that affirms commitment to your diabetes ed program, and in that letter of support, approval of required resources. That letter of support has to be produced physically, hard copy, and uploaded or mailed with your initial application as part of the initial application. Okay, the next step is assess the needs and goals of your diabetes population in your market area. Now, what I'm telling you here with these steps are not only going to help you organize your effort to get organized, but these steps are also required, ladies and gentlemen, to get that certification from either one of these associations. It's not only to help you get organized, it's required for certification. So we have to assess the needs and goals of the population in your area. And the needs and goals of the providers who's going to give you the referral. What do they want from you? Do they want just a diabetes ed program, or do they also want CGM, continuous glucose monitoring? Do they also want medical nutrition therapy? Do they also want insulin pump management? Do they also want a separate weight loss program? Do they want a diabetes prevention program? Do they want pattern management for patients with diabetes? So this is a golden opportunity to survey your providers to see what other services they want from you besides diabetes education. And then a step we all tend to miss is ask your sponsoring, your SO, your sponsoring organization, literally the president, the CEO, what are the goals of your program from their point of view, okay? Because the president may say to you, I want your program to make money. And then your next question should be, by what percent profit? 10%, 15%, 20%. Or they may say, as long as you break even, we're good. Or they may say, which the president said to me years ago, this was a Catholic hospital and the president was a nun, and she said, Marianne, I don't even care if you lose money in your new program. And I almost fell off my chair when she said that. And her name was Sister Kathleen. Unfortunately, she's passed away. This was years ago. And I said, Sister, I don't understand why you would permit me to lose money. She gets up from her desk, walks around to me, and she's got a surgical boot on her foot. And she said, Mary Ann, 2 weeks ago, I had half of my foot removed because of diabetes. And that's why I don't even care if you lose money. And again, to have business acumen, have business smarts, then we need to say, by how much loss, what percent loss will you accept? And that's what I asked her. And she says, oh, I would accept 10%. So getting granular and being able to meet whatever goals they set for your program is important, because they're holding on to the resources. And so meeting their goals is critically important. B, become fully knowledgeable of the certification organization, ADCES or ADA, whichever one you go to. Be really knowledgeable at the beginning of their application requirements, AR, their application requirements. And they're 90% the same, but they're about 10% different. And I will highlight the differences, because that 10% differences in the application requirements could make you choose one association over the other. And we will show you that, so just hang tight. Okay, the next step, ensure a full understanding of the national standards of DSMES. Really critical, because in my opinion, and I've been working with this for 20 years, I actually help clients independently get accreditation or recognition with my turnkey materials. So we'll talk about that a little later. So I know all this inside and out. I've developed the turnkey materials. I know what these associations want. And I would say 75% of what you're submitting to them in your initial application is proof, written proof and policies and procedures. I call it a policy and procedure manual of how you're going to adhere in detail to each of the 10 national standards. And just so you know, ADCES and ADA on their websites, they have published, and it's free to you, interpretive guidance of the standards, which is basically their way of telling you what you have to do for each standard in order minimally, not holistically, but minimally, to achieve that initial accreditation or recognition. Okay, the next step is to team up. What do I mean by that? You have to assemble your Diabetes Ed team of instructors and staff. Now, Standard 5, and we'll go through this, says that you have to have an RN, an RD, or a pharmacist on your team. That's or. I want to stress that. And some of the things I stress, you're like, Mary Ann, I can read, I see this. I don't want to offend you. When I stress things, it's because of my experience with helping organizations get this certification and some of the stumbling blocks that they struggle with. Because, you know, what's clear to me sometimes is very muddy to other people because they're new with it. And I understand that completely. So then we can also have on our team what we call community health workers or paraprofessionals, same term. And so what do the CHWs, community health workers, what do they do in our program? Well, they do primarily, and I said exclusively, non-clinical tasks. So connecting patients in the community with resources, connecting patients with diabetes, PWD, to your program, and also teaching in your program, teaching some really more basic topics like cultural cooking, how to fit in exercise every day. But they have to be trained by your staff, your instructors, your experienced instructors. They have to be trained on specifically what you're going to have them do. They have to go through an initial training on what you have them assigned to do, and you have to record that training curriculum, what you've put them through, prove that you've put them through that training, initial training, on what they're going to do in your program. And then annually, you have to give them a refresher training and record that. And that's part of ADCES and ADA requirements for your initial certification and every 4 year for your renewal of your certification on these CHWs, training them on specifically what you want them to do in your program. The next step, and this is partially required by ADCES and ADA, and tell you the difference, but I'm recommending some of this outside of the two associations. Establish a business plan. You know, we have to think like a business and act like a business if we want our programs to be successful. And I can tell you that, ladies and gentlemen, I get goosebumps saying it because 20 years I've been helping programs get this certification, helping them sustain their programs when they're being threatened with closure, how to get more referrals, how to get more patient attendance, how to prove their value. I do this almost day in and day out. And what I find to be as true as rain, as white as rain, is that a lot of us as clinicians, we don't think like a business and we don't act like a business. And I understand that. We're clinicians. We've been trained to focus on medical management, diabetes education, nutrition therapy, CGM. You know, nobody told us to put our business hats on. Nobody trained us in our 4-year degree or our certification classes to be a business person. And yet, without business skills, you know, in my opinion, you know, anything we do, if we don't input business skills, we're kind of doomed for failure. So there's really 5 key components in a business plan for a medical intervention program. The first is a continuous quality improvement plan. Now, a CQI project is going to be required, a minimum of 1 CQI project every year for the initial certification. Okay, you have to outline how you're going to do your CQI project, what are the details, how you're going to do it, all right? And then every year in your 4-year cycle, you have to do a minimum of 1 CQI project every year in the 4-year cycle. Really, really important. So having a CQI plan as part of your business plan is critical. Here are the 5, in my opinion, this is now my work, the 5 components of a best practice DSMES business plan. Starting at the top, we have the operations plan, and going around clockwise, marketing, financial, there's your continuous quality improvement, and then your clinical and teaching plan. Really critical to have these spelled out. What is the operations plan? What is the space for the classroom? Where are you going to have the group classes? How are you going to get the AV equipment? Are you going to use AV equipment? What are your teaching aids? How are you going to pre-register your patients? How are you going to staff? How many instructors are you going to have? Are you going to have administrative personnel, secretaries, part-time, full-time? How are you going to staff the program? Then your financial plan. Who is going to verify insurance coverage when the patients are registered? What are your reimbursement policies and procedures? Are you going to ask for a reimbursement tracking report? And if you're going to think like a business and act like a business, this is absolutely critical. And again, this is beyond the scope of the webinar to talk about each of these components in the financial plan. I'm just giving you a high-level overview. You have to be on top of your own budget. You can't let somebody else do that for you. You have to get and read regular financial statements coming out of your accounting department. Very important. And then your marketing plan. You know, providers are not going to refer to you if they don't know you exist. People in the community with diabetes will not self-refer if they don't know you exist. To prove your value to physicians and to mid-levels like physician assistants and nurse practitioners, you know, outcomes prove your value, tracking outcomes, showing them your outcomes in an aggregate summary. That's part of marketing, to prove that you know what you're doing and you're producing outcomes on their patients that they're managing, and they've referred their patients to you. And then showing your outcomes to patients, publishing them in newsletters to show that you're making a difference. And then we need a clinical and teaching plan as part of the business plan. You need a curriculum that's part of the application requirements by ADCES and ADA. You need to adhere to medical standards of care, such as those published by ADA. So there's a lot of things that go into the clinical and teaching plan that have to be developed as part of this initial application. Okay, the next step is to schedule dates and times of your first program, however you've designed it, and synchronize the flow of the patient arrival, the registration. And you're saying, well, gee, Marianne, what do you mean schedule the dates and times of my first program? I don't even know how to design my first program. And so what I'm going to do here is toggle over to this, and I think you can see it. where this is my, and you have this now, Gluco was kind enough to upload this for you to download. This is a DSMES record and progress note, and it's a design of a program. It's killing 3 birds with 1 stone. So on the left column is how I designed a 6-visit DSMES program. It's a combination of individual and group classes to be consistent with the 10 hours that Medicare pays in the first year for the initial DSMT benefit. So the number of hours is 10, consistent with Medicare, and it's 6 visits total, and what topics are taught in each visit. But then this also acts as an education record, and on the far, because you have to keep an education record for each patient, and on the far right, it's acting as a progress note to the referring physician after each visit, referring physician or referring NP or PA. So it's a design for you to help you out with that. It's an education record that you'd fill out for each patient, and you only fill out like DSME record visit number 1 and then the progress note. Then for visit number 2, you take out a clean form and just fill in where it says visit number 2. So it's important to understand how that works on the form. So let me go back to the PowerPoint. We want to train instructors and staff on all aspects of the program. Then we want to roll out 1 or 2 practice classes to iron out the kinks, and then recognize that we get robust resources from our 2 associations anytime we want them. Then we have to get a referral for the patients in the first program. Because if it's Medicare, we need the referral. And then you have to implement your very first program. Yes, you have to have 1 patient go through a real program as part of the application requirement by ADCES and ADA. You have to have the program up and running and send 1 patient through it and get all this documentation and completed forms in that patient chart as part of the application requirement. And then identify, once you do this first program with your first patient or more than 1 patient, because you need 1 patient with forms to send to ADCES or ADA, then look at your business plan and iron out any kinks that appeared. And then fill out and navigate to the online application, complete and submit, and then gather all your necessary information for the telephone interview, because once they approve your application and all your policies and procedures and your forms from your 1 de-identified patient, then they're going to do a telephone interview with you. So standard 1, internal structure. You have to define and document a mission statement and goals. You have to have a mission statement and goals written out to send to one of these associations. And then you have to show them with an organizational structure how your program fits into the structure. Just a simple organizational structure. Number 2, you have to have a stakeholder committee. Experts from external or internal who are going to help you promote quality and enhance participant utilization, a stakeholder committee. And there has to be a patient with diabetes on your stakeholder committee, and you have to have 1 stakeholder meeting per year with meeting minutes. That's going to be a requirement, but for the initial application, you have to have the names and credentials of each stakeholder on your committee for the initial application. Standard 3, for the initial application, you have to show how you're going to evaluate your demographic area, your geographic area, to define what population you're going to serve. What are the needs of the population? How do you define what population you're going to serve? Are you going to serve all type 1s, type 2s, type 1s and type 2s, gestationals? So to meet standard 3, evaluating your population you're going to serve, you should look at the prevalence and type of diabetes in your area, the demographics of these patients and their needs and expectations. What do I mean by that? Monroe County, Pennsylvania, 8.8% of their people in that county are adults with diabetes. And you're going to have to show this in the initial application printed materials. I call it a policy and procedure manual. My policy and procedure manual is in 10 sections, and every section is a standard. Standard 1, the national standard, Standard 1, that's the first part of the PNP Manual. Standard 2, second section of the manual. Standard 3, third section of the manual. And all of these requirements, you're writing out policies and procedures. Population, how did you evaluate? What's going on with your population? These are websites where you can get prevalence data, so this is good. And then demographics. What is the age, the educational status, the literacy, the numeracy? What are the demographics of your population? Again, here's Monroe County. You can read this on your own. What are their needs and expectations of your population? Basically, their availability, services. What do they want? What do they need? All of that has to be evaluated and put in print in your policy and procedure manual. How are you going to get this information? Call other DSMES programs and pretend you're a patient and ask what other programs are doing. Put surveys out for the patients within your organization when they come in for other medical services. Ask them on a quick survey. Or go to grocery stores and over on the left and ask them questions as they're coming into the grocery stores. Go to the church before they're walking into Mass or services on Saturday or Sunday with a little quick survey in order to, okay, Standard 4, you need a quality coordinator. Again, I don't read word for word. I just want to talk to you like we're here sitting around my dining room table. You need a quality coordinator. And again, a resume is going to have to be sent to ADCES or ADA, and that resume of the quality coordinator shows that she has experience in management and organization of a medical teaching program. It doesn't have to be specifically DSMES. It could be that she managed a cardiac rehab program, or she managed a diabetes prevention program, he or she. You know, if it's a DSMES program, all the better, but some kind of management experience in a medical education program, and also then experience with DSMES. She's going to have to show on that resume experience with DSMES. Okay, your team. At least one of your team members has to be a registered nurse, registered dietitian, or a pharmacist, or with training and experience pertinent to DSME. And how you prove that is with their resumes, okay, or CVs. If you don't have that, you could have another healthcare professional that is a CDE, now it's called CDCES, or a BCADM. So let's say it's a social worker who is a certified diabetes care and education specialist. That will meet this requirement because she holds that credential. But if it's an RN, RD, or pharmacist without the CDE, that's fine too, but she's got to have, he or she has to have proof on her resume that she has training and experience pertinent to DSMES. Really, really important, he or she. Now, when you talk about staffing needs, you know, how many instructors do we need? Do we need support staff for registration and outcome tracking and data management? Because we have to keep inputting data into an Excel file or one of the platforms that ADCES or ADA gives us to track our data. They have online programs for data input, data entry, data aggregation. They can help you with that, or you can use an Excel file of your own. Who's putting in all that data? The number of patients, the number of referrals, the behavioral goals, whether the goals have been achieved. Somebody has to enter that data. Staffing is going to be required. Or your instructors could be responsible for entering that data. So basically, when we talk about staffing needs, there are so many variables that go into staffing needs. There's just too many to even review now, but I have them listed for you here. Like, for example, the volume of provider and self-referrals. If you're getting 10, 12 referrals every day, you're going to have to run a lot of programs. Like when I did my program, I started a new 6-visit program every quarter of the year. I started one in January and then January, March, June, and October. January, March, June, and October. So I ran 4 6-visit programs a year based on the number of referrals I was receiving and we only had 2 full-time instructors, myself, a dietitian, and a nurse. But, you know, there's so many things that go into staffing. It's just tons. And I've got this listed for you here. Are you going to be offering other things like weight loss or MNT? That's going to affect your staffing. So this is what I did for you. This is an educator's schedule. I do want to spend just about a minute or two on this. This is one FTE diabetes educator's schedule for one day. And the reason I did this, ladies and gentlemen, I'll guide you onto what I'm doing here. If we look at the very first row, going from left to right, I scheduled this, let's say it's me, Mary Ann's schedule for today. She scheduled an initial individual visit, one visit today at 1 hour. Let's go from left to right. But I only have 15 minutes for pre-visit time and 15 minutes post-visit time to get ready for the visit and then after to chart. Then go to the column on the left, follow-up individual visits. I'm scheduled 1/2 hour follow-up visit. I get 15 minutes before, 15 minutes after. Then go to the column on the left again, group visits. I'm scheduled 1 group visit today. It's a 2-hour group visit. I get 30 minutes before that visit to get ready for it. I get 30 minutes after to do all that charting on all those patients in the group visit. All right, so now let's go down on the left again, the left column, day totals. 3.5 hours of billable time, 3.5. I'm on that row. Go to the left. It's 1 hour total in pre-visit time, 1 hour total in post-visit time. So it's 5.5 hours I'm going to spend doing my teaching, billable time and non-billable time, pre and post. So at the end of the day, I've spent 6.5 hours directly involved in DSMES, 6.5 hours. Some of that is billable, some of it is not because it's pre and post visit time. But look what I did in the column, up and down column in the orange. I was scheduled by my supervisor 1 hour for non-DSMES key tasks. What does that mean? I'm scheduled 1 hour to do marketing, 1 hour to do my work on my CQI project, 1 hour to identify why we're having problems with attendance in the program. So these are critical tasks that I've been scheduled to do that are part of sustainability for my program. That's absolutely required work. It's not billable. It's not directly involved in patient teaching or getting ready for the class or visit or charting after the class or the visit, but it's key critical task to sustain my program. And then there's break time and lunch, and that's my 8 hours. So it's really critical that you look at all your variables and then determine how many visits and how much time you're going to give your educators before the visit, after the visit, and do these other critical tasks. And remember, charting after a visit, if it takes an educator more than 2 minutes to chart after a visit per patient, it's too long. Your charting time is non-billable. You have to be very efficient about that and use templated chart notes, whether they're paper chart notes or EMR chart notes. If they're templated where you fill in the blanks or your queries that you answer, then the time is very quick, no more than 2 minutes on each chart note, including an education record. So we, just so you know too, that ADCES put out a position paper on practice levels for diabetes educators, level 1, level 2, and level 3. Level 1 is pretty much your, they don't have a lot of knowledge on DSMES. They're kind of support people. Level 2 is your typical diabetes educator who has that experience in diabetes education and or diabetes management. That would be me, for example. Level 3, you've got advanced expertise, and that's usually your BCADMs. You're board certified in advanced diabetes management. So you could have 3 levels of educators in your program. That's up to you how you design it. Now, again, we talked about what do community health workers do? They do non-technical, non-clinical roles and responsibilities. A lot of data management, teaching cultural cooking, how to fit in exercise, unique to the patient characteristics. So if you have a lot of Spanish patients, getting a community health worker that is of Spanish descent and can speak Spanish would be ideal. So I'm going to let you go through here these different roles and responsibilities. Again, remember I said that I wanted this to be your Wikipedia, even though I don't go over this word for word. I just wanted to give you an example of some of the things they do. But what is critical here is that you must, for accreditation or recognition, put them through an initial and an annual refresher, an initial training on what they're going to do and show proof of that, and an annual refresher on what they do in your program. Okay, you have to do that for ADCES or ADA, really critical. Okay, you need a curriculum, and the curriculum has to be evidence-based. And you're going to have to tell in your initial application, ADCES or ADA, the curriculum you're using by name. If you create your own, it has to be evidence-based, but there's so many good ones you can purchase, there's no need to create your own. Okay, individualization. Your DSME needs, your patient needs have to be individually identified. They have to be individually identified, which means each patient in your program has to have an education plan. And how you come up with that education plan is by having the patient, the participant, complete an assessment, and then the patient and the educator develops an education plan. And I have my education plan that you can download that I gave to Gluco to show you what it looks like. Okay, ongoing support. Before your patients leave your program, they need a support plan. And again, that has to be collaboratively determined by the educator and the patient. You also have my support plan that I designed that you can upload from the Gluco website, and thank you, Gluco, for uploading my documents. Participant progress. The provider of the DSME service has to monitor if the patients are progressing in their goals, their management goals. So each patient has to have at least one personal behavioral goal that they're working on. They have to have at least one. This is an application requirement. And you have to track if they're meeting that behavioral goal. They also have to have one outcome. They have to have an outcome measure that they're working on. A behavioral goal is different from an outcome measure. We'll show you this in a few minutes. Quality improvement. Basically, you have to do one CQI project per year in each of your 4-year years, each year for 4 years, a minimum of one CQI project. And for the initial application, you have to explain how you're going to do the CQI project, how many you're going to do per year, and how you're going to go about doing it. So what these slides show you now, because I want to save time for questions, this is really going to be helpful to you because you can see here that this is specifically ADCES accreditation or ADA recognition requirements for the initial application. On the left, you're not in the colored section, on the left, exactly what they want from you, documentation-wise, evidence-wise. Now, we've spoken to all of this, the organizational structure, the mission statement, the program goals, the letter of support. And you can see here on the right that if I say yes under ADCES, this is required for the initial application. If it says ADA, yes, 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 same thing. They want to see this documentation, and I call it putting all this in a policy and procedure manual. And my manual is 10 sections representing the 10 national standards of DSMES. Again, allocation of resources. That's your letter of support that the CEO or the president says, yes, we're going to give you resources. How are you going to overcome access-related problems? Well, you would write that in your PNP Manual. Quality coordinator's resume or CV, that has to be uploaded separately. And the list just goes on here. This is just really, I know you're saying, well, Mary Ann, this is so granular, but this is exactly what you're going to have to show, what you're going to have to upload or hard mail into ADCES or ADA as part of that initial application. And again, rather than having all these separate documents, I recommend that you do it in a policy and procedure manual with 10 sections representing each of the 10 national standards. That's what I highly recommend. Okay, so this is a separate slide that shows you what you need in that one de-identified patient chart. As part of the initial application, a minimum of one real patient has to go through your program, and you have to accrue a minimum of these completed forms in that patient's chart. Then you have to de-identify those forms, black out their name and any identifiers for HIPAA, and hard mail or upload this to ADCES or ADA, okay? I've given you all these things here you see in red is what I gave Gluco to give to you after this webinar. The only thing I did not give Ryan at Gluco was the referral form, and I can certainly give him that also. But you have all of this that I've created for you that is now yours, and you can modify them however you need. You can see here with ADCES and ADA, there's only one difference at the very top, outcome measure. The first row, ADCES wants a minimum of one clinical outcome measure that you have to measure on this patient. A1C, fasting blood sugar, postprandial blood sugar, it has to be clinical. ADA said it could be metabolic, which is clinical, or quality of life, That's the only difference in what they want in that chart. Okay, now we're back to the other requirements. Again, it's your list to go through. Now, the last thing, and then we're going to open it up to questions here. What is the difference here in ADCES and ADA regulation structure? ADCES has what's called branch sites and community sites. If you go through ADCES and you want to take your program off-site, you're at the main hospital, your primary site, but you want to have it in a clinic, you want to have it in a pharmacy. You have to earmark those off-site locations as either branch sites or community sites with ADCES. Let me tell you really simply, without muddying up the water here with this detail. Branch sites get their own ADCES accreditation certificate, and they can do their own billing. Even though they're tethered to you, the primary site, they can do their own billing, or the primary site can bill on their behalf. They can have a different curriculum and they could have different instructors. The community sites cannot do their own billing. The primary site has to do the billing. And everything at the community site has to be a Xerox copy of what happens at the parent site or the primary site, okay? So branch sites can be different than the primary site. Community sites have to be a Xerox copy. Branch sites can do their own billing if they want to. Then with ADA, it's pretty much the same, but they call it multi-sites and expansion sites. Multi-sites, again, they can have a different curriculum, different educators, different policies and procedures. Expansion sites have to be a Xerox copy of whatever's going on at the parent site has to be the same at the expansion site. And expansion sites cannot do their own billing. The parent site has to do the billing for them, okay? The only difference now, and this may be the thing that makes you choose between ADCES and ADA. ADCES, once you must complete the initial application and submit the fee. The fee is the same, $1,100 for both. With ADCES, you have to submit everything within 90 days of starting the initial application. It's the same with ADA. But look at the second one down, number 2. A test patient is not required from each branch or community site. This is for your initial application. A test patient is not required. ADA, yes, a test patient is required from each multi-site, but not with ADCES. Okay, that's really important. Look at number 4, ADCES. A test patient must have completed your program within the previous 12 months of the initial application date. With ADA, it's the previous 6 months. So you get more time with ADCES. That could make or break who you choose, okay? Everything else is pretty much the same. The fees are the same. Pretty much everything's the same on the fees. So the last thing, ladies and gentlemen, is people always ask me, how long is it going to take, this is the last slide, how long is it going to take me to get this accreditation or recognition? The slides I just skipped are all the variables. Did you already have a program in place before you started the application? Do you have your instructors ready? Do you have your quality coordinator ready? Do you have turnkey materials from somebody, or you do not have turnkey materials? So this is a table that I set up for you where I'm giving an estimate of how long it's going to take. If you look at the pink on the left, a lot of it depends on how much time you're going to dedicate to this task. If you do not have turnkey materials and you dedicate about only 5 hours a week without turnkey materials, so look at the row that says 5 hours a week, go to the right, and you have no DSME program implemented, it's going to take you about 24 months. Go to the green. If you have a DSMP program already implemented, I'm going to estimate about 18 months. These are my estimations. Go all the way down to the bottom on the pink, the last row. Without turnkey materials, you've got 20 hours per week that you're dedicating to this. With no DSME program, about 12 months. With the DSME program already implemented, about 6 months. And in the blue, this is my last comment, with turnkey materials, remember the table is without turnkey materials. With turnkey materials, you can reduce all those timeframes by 50%. Just to let you know, I have turnkey materials, and for you who have attended this webinar, I'm more than happy to offer them to you at a discount if you're interested. I'm not trying to sell my materials, I'm just doing this to help you get this accreditation or certification. So with that said, do your homework, be prepared, take the plunge. This is going to be really important, I think, moving forward.
Thank Marianne, and thank you all for joining us today for the 4th and final webinar in our 4-part Diabetes Connected Care webinar series. We would love your feedback on today's session, so please take a minute to share your thoughts through the survey that appears once you leave the webinar. We will be sending out the recording, the slides, and all the handouts that Marianne referred to today via email to all the attendees. If you're interested in viewing any of our previous webinars, you can watch them on gluco.com/webinars, which is on the screen now. And if you will be at the virtual ADA or ADCES conference this year, we look forward to meeting you digitally. Thank you all. Stay safe and healthy, and have a great day.
And please email me with whatever questions you have. Give me some time to answer your email questions. It's a little crazy right now. I'm busier than ever with COVID. I didn't think that would happen, but I am. But please, I'm happy to answer your questions on an email. Thank you all very much, and thank you, Gluco.